It's going to be important for us to really get more formal business training, because as we go forward, healthcare is changing dramatically. And as the model for healthcare is changing, physicians are not going to be able to sit on the sidelines and really play the role that we need to play. And for me, what happened was I was employed by a hospital, and I started realizing that certainly years of training gave me incredible clinical skills, but I was really at a disadvantage to really negotiate not only for myself but for the patients and to get what I needed for patient care. So, somewhat frustrated with my circumstances, I said, well, I don't have to be, have a victim mentality. What can I do to invest in myself and start learning more? And so it's been a crazy journey for me, but it's been literally 5 years, or even really more at this point in time, of embarking upon trying to get those business skills. And I've made a lot of mistakes along the way. It didn't need to take 5 years. There's so many programs now that are available that all of you can find and get these skills. And I've said to people, it would be the equivalent of saying, I don't know how to speak to those Frenchmen. And so I took French classes. That didn't turn me into I was, not all of a sudden French because I now know how to speak French, but it gave me an opportunity to, again, have a better dialogue with my administrative colleagues and not feel so vulnerable. And I think that part of the burnout that many physicians are experiencing is we have spent many, many years learning our clinical skills, and we don't really have the right language to really feel like we have control. So there's a lot of resources, and so my hope is to go through some key points about what's going on in healthcare, so you're just in a better position to understand the landscape, what it all means for you, and then give you some highlights on some of the resources that are out there that could help you. I'm going to tell you a little story. I'm fortunate enough to have been accepted into a master's program at Mass General Hospital, and it's at Dartmouth, and there at Dartmouth, this master's program, what they do is they bring to the forefront the Harvard and the Dartmouth Tuck School of Business leadership to really train physicians how to have a better understanding of the business of healthcare. So at this program, what we do is we study case studies of different hospitals, what challenges they're having, and how are they resolving those problems. So one of the recent studies we looked at was at Mass General Hospital and their pre-admission testing area. And what no different than a clinical case study, we go through the operational aspects of their pre-admission testing area. And what was happening was, here we have a premier hospital and patients are presenting to this facility. And when they present to this facility, they're waiting hours to see a clinician. And as we all experience that, as we're in a fee-for-service model, patients end up waiting hours for us as we're trying to just get our work done. But being Mass General and Harvard, these people coming in from a distance, that was just not acceptable to them. So they're having patients waiting hours. The doctors are getting the direct impact of that. Patients are grumpy, tensions are high. And so how do they solve those problems? Well, we might just come together on the front lines and have conversations about how we might solve it. But what you learn in programs like that is process analysis and business analysis. So you learn how to literally break down the process and create a process map. No different than many of us in healthcare. We'd say, what's the healthcare problem? And you'd have a flow diagram of how things all work. And then that map gives you a better sense of the picture. And there's principles behind how you would go about solving these problems. And so what they decided after they looked at the whole process, that obviously you want to get the patients in before surgery. They wanted to see all the patients before they come in for surgery. And as you know, this happens in everyday scenarios. And why are we doing that? Well, you want to make sure that when the patient goes for anesthesia, obviously, you've identified those patients that are at high risk, and you've done what you can to minimize that risk. So they put a tremendous amount of energy into that, trying to identify all the challenges that they faced operationally. And they came up with, there was some real problems that they were facing. how do you identify what is a complex patient? Because what they were doing was allowing the surgeons, as we all do, let the surgeons decide which patients might be more complex and which patients might be appropriate for a pre-admission testing area, and which patients you might want to say they don't need to go into this system and cause bottlenecks and delays. They're really a healthy patient. Let them just go to surgery, and we can assess that person on the day of surgery. The problem with that is, as many of you are probably aware, how do you really define a complex patient? And when we sometimes think a patient is healthy, you discover that very young person that you weren't so worried about was the very patient that you really need to be very concerned about. So unfortunately, there were delays and bottlenecks because complex patients weren't necessarily getting scheduled, and you have patients showing up on the day of OR causing delays in the OR. And for anybody who's in business, all that delay translates into unhappy patients and patients going elsewhere. And the time delays in the OR, when you multiply those time delays, no different than in your office, time is money. So it was costing them a tremendous amount, and they had to come up with new solutions. And this is not a unique problem. This plays out every day throughout healthcare. At our hospital at Meridian Health, and I apologize because the print's a little small, so if I'm not giving you all the details on the slide, I'll do my best to give you the pertinent points in the story. So at our hospital at Meridian Health, we had the same problem with this pre-admission testing area. But one of the things that we were trying to focus on was the management of patients with obstructive sleep apnea. So anybody who knows anything about obstructive sleep apnea, the problem with obstructive sleep apnea is most patients are not identified prior to surgery, but they are a high-risk airway. And when you fail to identify the patients prior to surgery, there's significant consequences for that. So we went about trying to come up with a solution, and as we started having discussions about it, what happened was a lot of the administrators who were approaching it from a business perspective got in the mix and never really even asked the physicians who were involved in the patient care what the process should look like. So they looked at this whole situation and said, well, if we start screening the patients preoperatively and identifying patients with obstructive sleep apnea, the prevalence is such that we'll start filling our sleep labs. So they were very excited to realize that there was a high prevalence of obstructive sleep apnea that might not be identified prior to the patients coming to the hospital. And here was a wonderful opportunity to start screening patients and fill the sleep labs. Well, I'm the director of the Meridian, the corporate director of Meridian Sleep Program, so that means they've expanded to 8 hospitals. So I have the lucky job of helping them put processes in place for the entire system. And I promise you, I said to them, I think that's really a bad idea. And they said, Dr. Ash, thank you very much. It's really nice. We appreciate your insight. And we, let us handle this. We're the administrators. This will all be fine. We have this all under control. And I just finally said, well, call me when you have the crisis. Because they proceeded to screen every patient across the entire system. And they decided, well, my goodness, if there's a large number of patients that are not being identified, and here's this perioperative opportunity, why just limit this to the perioperative space? Because we have the patients coming into the hospital every single day from the ER, from here, from there, and I said, we're probably at this point in time going to be looking at Armageddon at some point, but that's okay. Call me when you have the crisis. So, of course, they proceeded, and if you're not familiar with the perioperative screening tools for obstructive sleep apnea, what we use is something called stop bang. And essentially, that's a series of 8 questions. It's really simple. Each letter assigned to a symptom or an indicator for obstructive sleep apnea. So the S is snoring, T is tired, O, observed apneas. So each letter, a well-known symptom for sleep apnea. So if you have, of those 8 letters that you could possibly have, if you have 3 or more, you have obstructive, you're a high-risk airway, and you have a high likelihood of having obstructive sleep apnea. Now, the problem with this screen is this. So let me just give you one of the letters. So one of the letters, O, observed apneas. Now, if you have just that one, it's a high likelihood you have obstructive sleep apnea. But there's letters in there such as gender. So if you're male, so that would be 1 point. Your age. So if you're over 55 years and you're male, now you have 2 points. If you're male, you're over 55 years of age and you're tired, now you have 3 points. The problem is you just might be a party animal. And now you're scoring high risk for obstructive sleep apnea. So even though the score is a good tool, it's not perfect. Well, so you can imagine if you're screening 8 hospitals, screening every single patient that comes through that system, what we were left with. So, of course, like I start getting people who are involved in this process, panic struck, coming up to me going, Dr. Ash, I think we have a real problem. What are we supposed to be doing about this? And to give them credit, they hired sleep navigators because they thought, well, let's hire staff to organize this because they were already counting the money, I think, out of the volume they were going to get in the sleep lab. And so what happened was, as you can imagine, we ended up with 4,000 positive screens a month. And literally, we have 30 sleep beds for the entire program. So we have 4,000 positive screens a month. This started back in August, and literally just a month ago, I kept saying, they weren't giving me the numbers. Nobody was, because doctors don't understand data, I guess. So they weren't letting me know exactly how many, but I said, okay, I'm telling you right now, based on what I know about the prevalence and that screen, probably everybody in your hospital is screaming positive, even the therapy pets that are coming in. So lo and behold, we have 18,000 now positive screens, and we don't even know what to do with this. And so it just emphasizes that it really matters that when you are looking at your healthcare system and coming up with solutions, that you really understand the business aspect of it, and you work to come together as a real, true collaborative team. And you have to understand process mapping and really go about things in a good way. And that's just to emphasize that this came about because you had the physicians on the one side and you had the administrators on the other side. And we weren't coming to, I mean, if they had invited me to the table, we wouldn't have been in that spot. But we all have to learn to come together in better ways. So at the end of the day, what do we do about this? Well, it wasn't necessarily a bad problem to have. I mean, we now recognize that there truly is a real need. And it brought the administrators to the table to say, well, this is a real opportunity to bring a new care team together. And that's what we're doing. So we had the sleep navigators, but no different than a wound care team. Now what we're doing is we've created a sleep apnea care team. And it really matters because there is a true perioperative risk for obstructive sleep apnea. So when you fail to identify people with obstructive sleep apnea, and most often what happens, and I promise you, if there's any pulmonologists in the room or sleep specialists in the room, I get called all the time to race into the PACU to address the emergency because the high-risk airway was missed. And when you have a high-risk airway, anybody who deals in that area, if you have somebody with obstructive sleep apnea, you fail to recognize that they have obstructive sleep apnea. You don't monitor them properly, and you'll give them medications such as opiates, sedative hypnotics, that'll knock out their respiratory drive. And in these individuals, they're so much more sensitive to those medications. So when you get called into the PACU as a pulmonologist because of the negative pressure pulmonary edema, I promise you, more often than not, that's a patient that had an obstructive airway and they didn't recognize it as such, and they're pulling against the closed glottis, creating huge negative intrathoracic pressures, filling their lungs with water. And it's just typically that the root cause is missed. So the point being, we have to do a better job. The Joint Commission is going to be demanding that we do a better job. It will only take one. If you miss one of these patients as a physician or as a hospital system, the consequences are really significant because it's highly identifiable. This is what we call a never miss. So, we would be, when you think about what happens in hospitals, there's 30,000 to nearly 90,000 preventable deaths a year. Now, my husband's in aviation. I always find it interesting that when one prop plane goes down, they send out the NTSB to investigate. So one person, one prop plane, and we have an entire national system sent out to investigate. Yet if you had one patient death, very often it goes unnoticed. because we don't expect people to be in an airplane and die. But we've just gotten accustomed to people dying in the hands of healthcare. And you know it happens all the time. And so what's happening in healthcare is a tremendous amount of transparency and a tremendous amount of accountability, and these quality metrics are coming to the table because you couldn't go anywhere else in any other business where you would say, you know, for example, if you went to go get a meal and you had to wait 2 hours for the meal to come. It was cold, it was too salty, and you couldn't eat it. And they threw it on the table and were all grumpy and irritable and said, well, I'm really sorry, we had an emergency in the kitchen. You wouldn't pay for that meal. And so what's happening is in healthcare, people are asking of all of us, you know, for our care, they want low cost and high quality. And that's really where healthcare is moving. But having said all that, that's a heavy lift. So, you know, so cost has become a big issue. No one wants to pay for anything that isn't high quality anymore. You wouldn't want to pay for the meal that wasn't high quality. You wouldn't want to pay for the car that wasn't high quality. We all want a value. So, you know, going forward, we're going to have these high deductibles. People are going to have skin in the game, and they're going to want to make sure that when they get the care they get, that $1 spent in New Jersey bought them the same care as $1 spent in New York. So we're going to be, in New Jersey, we're going to be held to the same standards as the care they deliver at Harvard. And so that's going to take all of us to come together, not just the physicians, but we're going to need those administrative teams to put the resources in place so we can do the job well. So it's going to take collaboration, and as I mentioned, with our program, we realized we had to change the care model. We had to say we can't just make it about physicians. We can't keep asking physicians to come to the table and do everything. You know, what is it that we do well? You know, we need to be there for the complicated cases, and we need to have a different team that's there to support us so that you have coaches, APNs, different people in the mix that can deliver on what's needed. And so with our model, what we did was we said, okay, let's have an advanced practice nurse. She can be the sleep navigator that would be there right from the beginning to capture those positive screens. If there's a physician that's just unfamiliar with what needs to happen with that patient, that's okay. The patient would have that nurse navigator who could go to the bedside and educate them. If we found a patient that truly needed intervention, there's auto-titratable CPAPs now. You don't even need a sleep study. I promise you, you could just put the mask on their face, hit the on button, and these machines are so sophisticated they can monitor the flow, and you don't need these fancy sleep studies. So we have to come up with a different process, a different team. We can't use these time-consuming, costly tests. It's just really not feasible anymore. And you know, order sets, this is happening all over the place, but sleep is a perfect example of how we don't have the process right. And then on discharge planning, like any other diagnosis or chronic disease, you know, how do we make sure that that patient gets seamlessly over to the primary care so care can happen? And so why talk about this whole thing? Because it really hammers home, this is problematic. This is just one particular example, but it's really problematic what's going on. And there are true solutions to manage this better. And as physicians, everyone's getting overwhelmed and burnout. I don't know about you guys, there's days I'm just exhausted. But it's not impossible. We can turn the corner. But what I thought was really incredibly interesting about this whole case study that we did at Dartmouth, and I raised my hand and said, and we spent hours. What they do is they'll have these cases, and we dissect it down, we come up with our solutions, we make all kinds of process maps, and we do a complete business analysis of the situation. And I raised my hand and I said, what struck me about this particular case was all the hours that we're going into, how do we improve the pre-admission testing area? Because when patients arrived, we had to make sure that we understood their risk. So no different than your credit rating or your credit report, you know, where are you on the health spectrum? Now, when you think about this for a second, you know, for the general practitioners in the room and the specialists, are you going to tell me that the only people that know how to assess a patient's risk and understand are they healthy or are they sick are the anesthesiologists and the surgeons? You know that's not the case. The reason why no one's really assessing the health risk is because we manage disease. No one asks us to create a report card for a patient so they know exactly where they are on the health spectrum. So what struck me about this case was that this was a bunch of wasted time, that it should have been well known before the patient even needed surgery that they were high risk, so that only high-risk patients, because they were the ones that would need this kind of very involved, intensive assessment, were even showing up in the process. And so when you start looking at that, you realize that medicine in general, we are a disease management system. We're not a health care management system. And what, as a nation, we're starting to realize is that we need to shift that model altogether. And there are physicians out there that actually call themselves upstreamists. What they mean by that is, instead of waiting for patients to show up in your office with the crisis, they're actually going out into communities and screening whole populations and identifying within that population who's healthy and who's not healthy. And there's major efforts around this, and you may have heard of hot spotting and cold spotting. If you've heard those words, that's what it's about. It's about going out to the communities and doing risk, very, very assessment, way upstream. Now, interestingly, some of this movement for coming upstream started right in Camden. And what happened was, there was a gentleman from Robert Wood Johnson Hospital who wanted to be a neurologist and decided to go out into family practice, and he was all into data analytics and was having fun with the ambulances and wanted to ride with the ambulances to go out into the communities and really bring health care to the communities, and ran into some obstacles because the ambulances were unionized and all the rest of that, and they said, well, that's a really nice idea, but we're not interested in that, and started just tinkering with the data. And what he started looking at was, when the ambulances arrived at the hospital, what did those patients look like? I mean, I don't know what possessed him to do this, but this is what he did. And what he found out was that the vast majority of the ambulances arriving at Cooper for certain diagnoses were coming from 2 apartment complexes. And so he looked at that, and so you might look at the problem and you might say, how are we supposed to focus on prevention and wellness when you have 300 million Americans and you have overcrowded ERs, you have all these patients showing up? It just almost seems like it would be impossible to get your hands around it. But when you actually looked at the data, when somebody stopped to say, well, are these patients? What do they look like? They were coming from 2 apartment complexes in Cooper. What was happening was, when they went to these apartment complexes, they realized it's things that you already know. If you're elderly and you don't have good lighting, or you have bad carpets on the floors. So the environment where these particular individuals were living was putting them at risk for health issues, and they were coming in with all kinds of problems. And there were all the hip fractures, for the most part, it was like about 90% of the hip fractures that were arriving at Cooper were coming exclusively from these 2 apartment buildings. And they realized all the millions of dollars that were going into health care could have been solved with carpet. So it was, I mean, you can Google it. It's hot spotting. It's like one of the hottest things going on. So this was Camden, and people said, my gosh, if we can do hot spotting in Camden, can we reduplicate these efforts? So Intermountain Health, you may have heard of Intermountain Health. It's one of the, we know Mayo Clinic, we know Harvard, we know names like that. They said, well, let's try and see if we can reduplicate it. And lo and behold, you can see that when you look at the geography of a state, you can literally find the pockets of disease and where they're coming from, and you can go into those sites and you can really identify simple things that would have stopped them from coming into the system in the first place. So what that does is it changes things altogether, because if physicians are completely overwhelmed and we can't handle the volume, and we've got a healthcare crisis, and we've got all these people with chronic disease, children getting more obese, and that the rate of that rising at an alarming rate, and addiction like we've never seen before, then what do we need to do to find those hot spots and turn that around? So the business of sleep medicine is a perfect example of how we have this all wrong. And why is it a perfect example? Well, I'm here to tell you, and I apologize for any sleep doctors in the room that are going to want to find me and run me over with their car. But if anybody knows anything about the process of sleep medicine, the vast majority of those sleep patients do not need an in-house test. In fact, the vast majority of them probably wouldn't even need a sleep test at all. In fact, you can make the diagnosis of obstructive sleep apnea based on history alone. I mean, honestly, if a patient is telling you they're falling asleep during the day, they're morbidly obese, they have a big, thick neck, they've told you, I wake up choking, gasping. I have patients who have said to me, doctor, I have that sleep apnea. And when you send a patient for one of those in-house tests, it costs anywhere from $5,000 to $10,000, depending on the hospital. A lot of you don't know that because you don't see the bills. But that's what hospitals are charging. Now, let me ask you something. Seriously, $5,000 to $10,000 for snoring? I mean, that's really insane. And when you look at the criteria for the in-house test, we love telling you all this. Well, you know, there's indicators that they need the in-house test. This would be the equivalent of getting a CAT scan on everybody that had a cough when a chest x-ray would do, or maybe even a lozenge would do. But, you know, when you have revenues attached to a study, you can't even help yourself. You know, you're going to find these patients. My hospital was just salivating over 18,000 positive stop bangs at $5,000 to $10,000. We were all going to get our big bonuses at the end of the year. But it just highlights that this is a problem. Now, going forward, and 75% of sleep specialists are pulmonologists. Now, how did that happen? Now, I remember Michelina was in that sleep lab. It's because sleep disordered breathing, and it was just a natural transition for pulmonologists, because nobody knew what was going on with this. This was some like big mystery space. And I remember when these sleep studies, we all thought it was like voodoo. Like, what is this stuff with these lines and squiggles and all the rest of it? Because none of us got exposed to it in medical school, and we love that you thought it was all mysterious. And you could ask Michelina, was this that mysterious? You were either sleeping or you weren't. You were either breathing or you weren't. And that was the size of it. And, you know, hours and hours and hours to learn the secret language to tell you, yeah, they have sleep apnea. I promise you, you could watch them for 5 seconds and know they had sleep apnea. You didn't need hours and hours and hours and hours of these studies. But again, the money was there and it was good. So pulmonologists went into this, and now there's a realization that we have a real crisis in sleep medicine, because there's a recognition that sleep is the backbone of health, and that millions upon millions upon millions of Americans are dealing with chronic insomnia, which we didn't learn how to. You can't be the jack of all trades. You can't be the ICU doctor, and any of you, I mean, seriously, we're all going to get hit with this too, because if you code for critical care, it means they're critically unstable. So I love when my critical care colleagues run into the hospital, see their critical care patient, code for critical care, go back to their office, and now they're stable over here in the ICU. So they're done with their office hours, they're back over here. They're all unstable again. We're all coding for critical care. These are the things that we're doing because it generates revenues for us, but it doesn't do anything for quality of care, and it just increases the cost. And again, sleep medicine is a perfect example of that. So we're you know, we've created our own monster, and now we have to undo it. So it's sustainability, there's no sustainability here, and it's an avalanche of problems. So we're being asked to, you know, not do things that are very costly. The way we do things with sleep medicine, that's a very time-consuming test. Realizing that you now have commercial drivers that are struggling with obstructive sleep apnea, and you have in New York Transit, the whole train went off the rails because an individual was missed with obstructive sleep apnea because nobody asked. We just can't continue like this. So we need to move upstream, and we need to get to these people before the crisis. There's no point in waiting for them to come into the pre-admission testing areas to solve these problems. And I promise you, what I love about the osteopathic profession and being a DO, we already all knew that. We're the ones who did the rotating internships. We're the ones that, you know, because now the whole thing is we need to manage the whole person. We were already doing that. And so I think it's just very, very interesting that we're transitioning to this population health and value-based care, and we were already there. So I'm going to run through what does that really look like. So the business of medicine, you've heard a lot of sayings, fee for service. Essentially, for those people not familiar with the language, fee for service just means you see the patient, you get a fee. We're moving to shared risk, and we're going through pay for quality. That just means metrics. We can't test obstructive sleep apnea patients and then, oh, I'm so sorry, you're not compliant with the equipment. So we make $10,000, and what have we done to advance care? Shared savings, so if we're delivering on quality, we get to share in the savings. Bundled payments, that means if you're coming in for the pneumonia, you don't get a separate fee for the pulmonologist to see you, the infectious disease doctor to see you, the family practice doctor to see you, the ENT doctor to see you for your sinusitis, and paying for the chest x-ray too. One fee for the entire episode. And the intent was the Affordable Care Act signed into law, the intent was by January 1st, 2015, to move the entire healthcare system to bundle payments. They're just starting with joints. That just started. If anybody's an orthopedic in the room, you know that bundled payments have come to your joints. So it's one fee, and out of that fee, everybody has to get paid, no more, no less, and it's on average, what does it cost to get a joint through on the national average? And we're gonna all be held to the same quality and standards that this Hospital for Special Surgeries. So their outcomes have to be our outcomes now, and if you can't meet it, your reimbursement will go down. And then we'll be moving to shared risk. And shared risk means the hospitals are going to be the insurance carriers. And that's where hospitals are moving, to an insurance carrier model, where they'll really be responsible for making sure we keep people well. So currently we have a U.S. healthcare system where the top 1%, as you all know, are taking up all the healthcare dollars. And you have this pyramid, but there's a realization that there's a lot of roads along that pyramid, and we have to pay attention to all those components. Here's the roadmap that we're on in terms of the payment models. And as I said, we're at fee for service, and we're moving towards this model of shared risk. And the Accountable Care Act, there on your far right, where we're going to be looking at the triple aim and delivering on the triple aim. And all the triple aim is asking us to do is make sure we deliver care that's high quality, low cost, and that's what value is. So if you have high quality, low cost, you have a value, and that we improve the patient experience and we improve health for the population. So where were we? We were at a system that did not put the patient first. It was really a business built around the providers and foremost physicians, and a physician business. And you might have heard a lot about this patient-centric care. It's basically saying, well, really, what's the model that works best for the patient? And meeting them where they are instead of trying to make a model that works for physicians. And the Affordable Care Act essentially just came in and put the laws around that. And the Affordable Care Act has two parts to it. So it's bringing into it consumerism. And when people say that, they don't necessarily understand what that word means, consumerism. But when you study principles of marketing, there's a whole science behind why people choose what they do. And it's called search criteria. And so it's bringing that into the mix, and it's holding people accountable for those high deductibles. Again, we'll make sure that they have skin in the game. And so when you're spending your money, you tend to really make decisions about where you want that money to go. So unfortunately, healthcare is very complex. So I use the example of the restaurant meal. Well, you could taste that food and you know it's horrific. But unfortunately, it's very difficult for the average person to know, did they get a good value or did they get quality with healthcare? And I remember we'd be nights on end in the ICU, and there was one family practice doctor who'd show up at 7 o'clock in the morning after we were all exhausted, and we spent hours getting their patient to the end point and keeping them alive. And this guy, his patients loved him. And he would show up and he would give the patient a hug and he'd be like, Dr. So-and-so, you just saved my life. We'd all be sitting there going, we were exhausted. And I just realized, that's all they knew. That they knew the relationship, and that mattered more than anything else. And they had no way of assessing what we did was an incredible feat of courageous acts, jumping through hoops, and all the rest of that. But that is it's very hard for consumers to understand whether they're getting a value from healthcare. That's why all the metrics. So we're all going to be scored, so that when patients spend their dollar, they can decide: do you want to spend on the cheap quality or the low quality? If you want to spend fewer dollars, or do you want to spend on higher quality? And what's coming, whether you realize it or not, is incredible transparency, so patients will even know what everybody's charges are. There's companies out there that are creating financial transparency, and almost like the financial Uber for healthcare, where patients will actually be able to say, I need an MRI, and they'll be able to put into their phone an app that will tell them, well, the doctor that would read the MRI within, traveling distance of you has a 4-star, a little bit outside your circle. Here's a 5-star guy, but the 5-star guy charges $600. This one charges a $300. You decide. You want the 3-star with the $300 or the 5-star with the $600? And those are the kinds of things that are coming where patients will be making those kinds of decisions. So a lot of problems with the Affordable Care Act, but it's here to stay, and we're stuck with it. These IT platforms, changing the model, a lot of issues we have to deal with. And the triple aim, I mentioned it, but now there's a realization that we need the quadruple aim, and that brings to the picture physicians again, I'll be the first one to say it, are exhausted. And you have a lot of problems right now, because when you understand change models, right? If you had a paper calendar and your iPhone came along and you had to take all your addresses and all your phone numbers and move it over to your iPhone, right? Wasn't that just, I remember I resisted it forever, because whenever you change, it gets worse before it gets better. So when you understand these change models, we're in the dip. It will get better. So again, the triple aim is about changing the way we deliver care. It's lower the cost, and we can't continue the way we are, by the way, on the cost curve, because currently, as you all probably know, healthcare takes up 17% of the gross domestic product. If we continue the way we are, by the year 2040, it will be 50% of the gross domestic product. There's no one that can take half of their earnings and pay for healthcare. That's where half your taxes will end up going. The employer-led healthcare revolution. There's an article that was just out last summer in Harvard Business Review, where large employers are starting to realize that they just kind of looked at the healthcare providers as, well, they must all be doing good, right? They forgot to ask the sleep doctors about the $10,000 sleep study for snoring. So large employers look at their vendors, and they expect of their vendors low cost, high quality. And you may have heard of the Six Sigma and the Toyota way. So if you're a vendor for a large employer, they demand that you deliver on those parameters. No one ever delivered it of healthcare. And it's an interesting article. It was actually somewhat of a sad article, because when you read the article, why they're saying the employer-led healthcare revolution is because large employers have given up on healthcare. And what they're essentially saying is, all of you, and I'll use me as an example, all of you that are charging $10,000 for snoring, you just can't give up your cheese. And we can't depend on you to come to the table to do the right thing for patients and what needs to be done for healthcare. And I think that's just a sad statement. It's not that we can't do it, it's that the current incentives are aligned in a way that we get paid to do volume, and we get paid to run in-house sleep tests when a home sleep test or even a history would do. And we need to realign the incentives in a way that value what physicians bring to the table, that value what providers bring to the table, and you get a fair dollar for a fair day's work. So I think that that's really an unfair statement, saying that the employers have to lead the way. And I think that's a mistake that all of us are making, that we're letting them lead the way. And it's because we haven't done our homework to get the skills to be part of the conversation. So when they have in their language the iron triangle, which looks at access, and each person, each stakeholder at the table has something else that they value more, but it all comes down to the same. So what is population health? You hear a lot about population health. It simply means improving the health for populations and using a finite number of resources in a way that we get the biggest bang for the buck. And the problem is that sounds good. How do you take that from just a conversation to reality? So and this is it's a take on that triple aim. That's what population health is. And it's a question of, can we really do it? And I truly think we absolutely can. There's multiple strategies to deliver on population health, but it's about what are we trying to change when we talk about population health? You know, who's necessary to make this change, and how are we going to go about it? Well, the who, you know, who's necessary, that's all of us, but just not all of us. It's going to take healthcare providers, and it's going to take communities in ways we've never considered before. And some of the strategies are going to call because we can't keep putting all the burden on the healthcare providers. So for instance, if you have an obese child, we're going to have to partner with supermarkets. And some supermarkets, believe it or not, and the ShopRites here in this area, the Wakefern ShopRites have hired 150 dietitians, nutritionists, so that when you go to the ShopRite to purchase food, that as a consumer, you can work with a nutritionist to make sure that you're really truly buying healthy options. And why would they have an interest in this? Well, they can't afford the health care for their employees any longer. So in ways that we couldn't imagine, communities are showing up to try and solve this problem. Well, as healthcare professionals, we have to link with communities in different ways. So we have to connect with each other. And so we think of healthcare as the bricks and mortar. That's like thinking of planting trees and having a tree farm is going to create a rainforest. If we're really going to improve the healthcare for everyone, we have to just think about things in different ways. And so population health, and there's big layers there, and the point of all of that is there's many, many, many pieces to this whole population health. It's just not about the providers. So you need policymakers to come to the table and change policies so that you have school lunches that are more nutritious. And we just can't keep talking about doing it. They need to make these things happen. And then, again, as I suggested, the supermarkets need to change their offerings and take a responsibility in this. Where I live, I have the Saker ShopRites. And just about a month ago, they moved all the organic foods up to the front of the store. It used to be when I walked into the supermarket, and I guarantee you, if you go into your supermarkets, what's the first thing you see? The bakery and the cupcakes and this and that. And I walk in the thing and I'm like, oh man, they look delicious. And so my supermarket has actually changed it all around now. And all the organic foods, fruits and vegetables right at the front. And that's the way it needs to be. And obviously we need to bring those costs down for those items. And so there's a lot of ways that we can make this change. The point being is, of all these different layers, you need to just pick one and start. And if all of us just picked one and started, we'd start to break this down. So when you look out there, and you can see there's layers of this, but when we start focusing on these upfront, we call them health determinants and social determinants, we'll get to better health outcomes. So now, population health, went through it a little bit, but the thing that is something that is happening very fast is this concept of the action cycle. So any of you seen the action cycle with the Robert Wood Johnson Foundation? If you haven't, what's happening on a national level, I talked about individuals and saying we need to give them screening questionnaires to create their credit report, understand their health risks better. What's happening at a national level is they're starting to rank each state and each county on how well we're doing and giving the states and the counties health reports. And they're going to link us all together, so government agencies, organizations in a county, providers in a county will all be held accountable for improving the county score. And that's being really promoted by the Robert Wood Johnson Foundation, and they call it the action cycle. And you can see the points in the action cycle. The community is in the middle, and all on the outskirts of the circle are your healthcare providers, businesses, government, policymakers, so that health involves all of us and all of those elements. By the way, New Jersey's health ranking is 34 in the nation. So actually for rankings, we're miserably behind the rest of the country. So I promise you, if you think it's really bad, because I'm with Meridian Health, they're soon to merge with Hackensack. And I also do some per diem work at Barnabas, Robert Wood. Together, they control 60% of the market share of New Jersey. So I promise you, there isn't a physician or a healthcare provider in the room that isn't going to be touched by what they're doing. And when you go out there, people will tell you in another 5 to 10 years, there'll be no more than 12 healthcare systems nationally. So this is not going away. It's going to continue to move in this direction, and we're all going to have to learn how to partner together. So what works for health? It's again, these partnering together in different communities and everybody playing a bigger role. Real world challenges. What is interesting, currently there's a recognition that it's not that we don't have so the evidence is out there. I already know, the evidence is already out there. I don't need an in-house sleep study for everybody, but we're not applying the evidence. What is amazing is there's $100 billion that are spent on research. The evidence is out there. Only a small percent of that money, like 3% or so, is actually spent on implementation of that research. And it takes anywhere from 15 to 17 years for, even if if you went today and you read it in the New England Journal and it was profound, it was the pill that was going to cure all of heart disease, you would not see it until another 15 to 17 years. That's a hard, cold fact. We can't wait 15 for 17 years for healthcare to be implemented in the real world. So there's a realization that, and why does that happen? For those of you that are working at large universities, you have the academic guys that they're not running around ragged like the rest of us out in private practice. So they're spending the time, they're learning the science, they're implementing it. For the rest of us in the real world, we don't have all the resources. I have a friend who's a high-level executive at Stanford. They have a problem, they throw $60 million at it. I'm not kidding you. $60 million is nothing for them. They get donations like $200 million at a pop. When you don't have those kinds of resources, you're out in a community, the community doctors are like MacGyver doctor. You just find what you can. And so this is all great for when you're a university with all the resources that they have to implement these things. But how many Ivy League programs, how many universities are there? The vast majority of healthcare is delivered by community hospitals and community doctors. So if we're ever going to fix this, we have to even collaborate differently. And new models are looking at bringing in those researchers for those academic centers and partnering in new ways with community hospitals so we're all together in the mix. And then the community becomes a living laboratory. And you already know this is true. Like, how many times has drug research been done? And then it gets out in the population, and suddenly adverse effects that you hadn't seen before, because you're dealing with a unique patient population that's showing up at some of these university centers, not the patients that we're necessarily seeing. So we're going to be, health outcomes, looking at when we do an intervention, what does it really do for our patients, and not doing sleep studies without caring about whether or not they're actually being treated. And recognizing that we're going to have to make access points really convenient for patients. So health determinants, and I'm going to talk about that in a minute, health determinants are the very basic things that we need to do for health. Social determinants are like things going in and making sure patients have housing and things like that to be well. But looking at why are we waiting? So there's a big thing going on. Hackensack just signed a contract with Uber to get patients to the hospital when they don't have transportation, because you can't get to the hospital if you don't have transportation. You can't get health care. And I look at that and say, well, isn't that kind of costly? What about if we took all the healthcare providers and brought them out to churches, beauty salons, the malls? Believe it or not, hospitals are doing just that. Like, why not meet the patients where they are instead of waiting for them to come to us? So health and social determinants are going to be a major thing going forward. This is where we're moving upstream, focusing on behaviors, education, looking at whether patients are employed or not, looking at biology and genetics, early childhood development, that community support, and health care, not disease care. Now, what are box 3 results? This is something that we fail to recognize many times, that we have two types of operational systems in any kind of business and in healthcare. Healthcare has been the same for many, many years, and so we just needed the doctors out there implementing the science as it was developed, and you just had the people in the hospitals and in your office managing that process. Things are moving so quickly now, we need to learn new ways of doing things. So box 3 results, what it talks about is you have to always have a system that manages what you have. So managing means you had an idea, it was good, it was sound, and now we want a large number of individuals to implement that idea, where you have to have conformity and rules and standards so that you can meet quality metrics. But when you're innovative, when you're trying to come up with new solutions, in fact, that type of ability means you have to be willing to go into chaos, and it's in chaos where the innovation lives. And believe it or not, what people are realizing is that physicians, because in this regard, we're being left off the table with some of the solutions for healthcare. Physicians are some of the most innovative people going, especially if you're out in the community. Because you have to go in, right? Don't you have to go into chaos sometimes? An emergency situation, assess the situation, look for patterns, figure out what the problem is before you can even come up with a solution. We do that all the time. We deal with complex, chaotic systems, drill down immediately, find the patterns, bring it together, and come up with a treatment plan. Well, that's innovation. And we just don't think of ourselves that way. So as we go forward, we need people that can go in and disrupt what it is and be fearless about it, be courageous, have emotional stability when you approach it, and come up with new solutions. Well, there's no better person to do that than the physicians, because your brain is already trained to do that. We're just out in our office just continuing to manage the way we always have and not realizing how critical we could be for the solutions. So box 3, what that means is, box 1 is where we already are. You need management to maintain the standards of where we already are while you're moving towards a new framework of change. But you always need to be looking towards the horizon. Now, here's an example of that. So there's always weak signals to tell you, if you're paying attention, there's always weak signals to tell you where you're going to be 10 to 15 years from now. So if you could have looked back in the 1970s and said, okay, we have Atari, what could we do with this? You might say, you know what, gamification. As healthcare providers, somewhere in the future, we'll have the ability to have apps and games that could help patients learn how to do things. And we actually have that now. We have gamification of healthcare where we're helping patients learn new and healthier behaviors in games. And so, if you went back and Atari came into the mix, you would have never thought that somewhere down the line, that's what we would have been using to teach patients. So how many of you have gone into Staples recently? Have you seen those 3D printers, right? So I don't know if you've looked much into these 3D printers, but they're now available. They're in Staples. I was there the other day. So for $3,000, does everybody know what a 3D printer is? So for those who might not be familiar, it's a printer that literally you put the information in about an object, and it literally, layer by layer by layer by layer, reproduces this object. So by the time the 3D printer is done, you literally have a microphone or a clicker. So in the future, they anticipate that we'll get so sophisticated that you could put in the parameters for a kidney, and microscopically we'll be able to, at some point in time, have a 3D printed kidney, and transplants will be the thing of the past. Now, that's a very sophisticated, complex thing, but I truly believe that would be feasible somewhere down the line, but I think very somewhere down the line, because that's complicated. You need the DNA structure, you need a lot of things. But what's not very complicated is it's not out of the realm of possibilities that 10 years from now, you'll give a patient a script for a pill, and they'll go to the pharmacy, and the pharmacy will print it up on the 3D printer. I mean, there's only so many elements on the periodic table, right? And a pill is just a combination of those chemicals and those elements. So when you realize what box 3 thinking is, it's looking at the weak signals now and saying, okay, let me get in the 3D printing business, and 10 years from now, I'll be the next, Microsoft because I thought about it early. That's what box 3 thinking is. Identifying the weak signals that suggest a future opportunity and acting on it now. And really, it's really an important thing for people to learn how to do, and it's a learned skill. We all really could be a Bill Gates if we focused on box 3 thinking, and physicians are prime candidates to participate in that kind of thing. So you want to be, again, a supply chain innovator and changing the process of care and thinking of things like that. And when you're a disruptor and you're an innovator, there's a couple of things. You have to create urgency. You have to get people believing this really needs to be done. You have to have passion for it. You need a champion for the cause. And I'll tell you something else. If you're a disruptor, you got to be okay with isolation. because people are going to call you crazy. You're going to be the guy that's out there in chaos. They're going to say, oh my gosh, this is, but that's what it takes to be a disruptor. And because people don't like to be different. They like to be the same. But to be a disruptor and to be really innovative, you emotionally have to be okay with being alone. But when you get to that point that you're okay with being alone, it's kind of a fun place to be. Who are the scrubs and the suits? Well, we all know who they are. It's the administrators and the physicians. And there's a whole new science around. We can no longer just be scrubs and suits. That we can no longer be us or them. It has to be us and them. And I promise you, they need us more than we need them, but we truly need each other. And we are never going to solve this problem if as healthcare providers, we don't do some simple things to learn the language so we can talk to them better. Because it's very interesting when you start taking these business courses. And how it started for me was, again, I was struggling. I was employed by a hospital system, and I was getting eaten alive. And I said, well, my gosh, I figured out freaking ventilators. There's got to be an article about how do you run a meeting. And I literally just Googled, how do you run a meeting? And suddenly all this stuff started popping up. And I found some of these organizations that are out there. This is really an important point. This is currently the way the system is right now. We have the CEO at the top, the doctors, the patients, and we have a bricks and mortar system where we have one doctor, one patient. We're going to be moving towards a system where it's really the community at the top, and we don't want people to be patients. And you're going to have the doctors supported by new teams, nurses, coaches. And I would say to any of you, go out there and Google IORA. It's a brand new healthcare model. It's amazing. They're using coaches in ways you could never imagine. And the coach is like the buddy. These coaches actually stay with the patient, come into the doctor's visit with the patient, sit there and take notes for the patient, spend time with the patient after the doctor's visit so they understand all the questions, and stay with the patient across the healthcare continuum. It's like having a doctor in the family. Or the new liaison for healthcare. And that will allow us to go from one doctor to many patients. Because if we're going to focus on health and prevention, you can't do it. There's 300 million Americans. We don't have enough doctors to do health and prevention. So we have to come up with a new team. And that's essentially, this model is just showing you we're moving upstream. You're going to see more and more group visits where you'll have one doctor. And this is a very common scenario in diabetes management, where you have one doctor with a group of patients. And you've seen the things in psychiatry where they do that with group visits. All of healthcare will be moving towards that. And then you'll have the patients supporting each other. And then you'll be in a place where physicians will be seeing the very complex patients, group visits for those patients that are moderate risk. And if you're really well, I mean, really, folks, let's face it. Like, what is a wellness visit? If you're out in the community and you don't know that a blood pressure of 120 over 80 is okay and you got to go see your doctor to get checked for that, I mean, that's really not a good use of resources. So shared medical appointments and the group visits, it's already with us. And if you haven't been involved in some of the technology for healthcare, hold on to your seats. Because I just got really lucky enough to meet some amazing people in healthcare. And so I'm sure you all know who John Scully is. And some of his business partners have come to New Jersey. I promise you they have. And what is happening on a national level is there's doctors in other states that sit in community hospitals that aren't like New Jersey, but they have incredible scores. They have all the time on their hands in the world. And they're reaching out to patient populations in New Jersey in ways we've never seen before. And it's happening in real time. You have TeleDoc, MD Live. There's so many programs. And if you haven't, go to TeleDoc and just log on and check this thing out. It is unbelievable. So how it works is if you're a patient or you're someone in the community, you just go to this app, you register for it, and TeleDoc actually has a panel of physicians that are waiting for these TeleDoc pings coming in on their phone. And it would be if you were a patient and you had a rash, you take a picture of your rash, you upload it into the TeleDoc app, you go and you pick your doctor on the TeleDoc site, you click and you say, yes, I would like to speak to the doctor shows up on your phone and takes a look at the rash and says, aha, looks like poison ivy. Clicks a button, sends the prescription to the pharmacy, and you go pick it up, all for $40. That's happening real, that's happening now, it's happening in New Jersey. So you don't just have competition amongst your own physician groups, you have national competition. And WebEx and all the rest of that allows for patient visits, not just the teledoc and these apps that monitor all your different vitals, and just all new ways that healthcare is rapidly changing. You know, and I mentioned somewhat before about the research opportunities. So there's numerous research opportunities where we'll have, again, the universities coming and partnering with community doctors in a way we haven't before. So, I mean, for some people it might be like, oh my gosh, I was just trying to get through mock and recertification. And I don't know if any of you are doing that. I'm pulling my hair out with that myself, to be quite honest with you. And it almost seems daunting and overwhelming. But in truth, when you really understand it, I'm not that pessimistic about our future. And honestly, the next little section that I'm going to do for you will help you realize that, in fact, if you're an osteopath, you're positioned very well for the future. There's plenty of opportunity. And so what is the vision? The vision is we're going to have to deliver on that triple aim. We're going to have to develop measures for health rankings. You know, if you said, I'm not even sure what she's talking about, you will in a year's time, because it's coming. The ability to rate a patient and give them a credit score on their health. And that credit score will be attached to you, it'll be attached to the county, and it already is attached to the county, and will be attached to the state. And go visit the Robert Wood Johnson Foundation Action Cycle, you know, the county roadmaps and ranking site, and you'll see it's already out there. And we need to get people managing their own self-care. There's so many things that patients can do to help themselves. And so new models and new learning. So the sites that I have here, you know, understanding population health, how it became very easy for me is I joined the American Academy of Healthcare Executives. And you might say, what is that? You know, no different than we have the ACOI, the AOA, AROC. Healthcare executives have the American Academy of Healthcare Executives. And it's a very easy thing to do. And if you look at any of your executives, they have after their name FACHE, or F-A-C-H-E. That's what it is. It's a fellow in the American Academy of Healthcare Executives. And my friend dragged me to the first meeting that I went to 5 years ago. And I said, so let me see if I have this right. So it was all the C-suite people, so the presidents, the vice presidents, the CEO, and I'm thinking me. I'm like, oh, great. But I was amazed because they really get very excited when physicians and clinicians show up, because believe it or not, many administrators realize they really do need us. And this is an unbelievable education that you can get from this site. There's the Physician Leadership Group, which is, it used to be called the American College of Physician Executives, the ACPE, and it's now Physician Leadership Association. That's where I figured out how you run a meeting. And there's a whole science behind running a meeting, believe it or not. So there's a whole language, there's a science, there's nothing mysterious about it. So no different than I didn't want you guys to know snoring wasn't that hard, and all those squiggles didn't even matter anyway. This language is something that kind of keeps us separated, and not a good thing. And the Institute for Healthcare Improvement is another incredible resource that you can get some learning and be part of the mix. Meridian's tagline is, you don't get into something to test the waters, you get into things to make waves. So I hope you're all planning on making waves and proceeding forward with just learning all you can, because there's a lot to do. And I think there's a lot of opportunity if you're willing to just put a little elbow grease into learning about it. It's not that hard.